Ujú. Hola, buenos días. Continuando con el programa, hoy nuestra segunda ponencia del día, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y presidente del World Congress, The World of Neurosurgery in Your Fingertips, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi, presidenta del capítulo de la Asociación Americana de Neurocirujanos en el Instituto Politécnico Nacional, al doctor Salim Abdraouf, presidente de la Walter Dandy Neurosurgical Society, al doctor Babak Kateb, presidente de la Society for Brain Mapping and Therapeutics and Brain Mapping Foundation, todos ellos vicepresidentes del comité organizador, y al doctor Parmenios Guadarrama Ortiz, director del Centro Especializado en Neurocirugía y Neurociencias México. Y es para mí un honor presentar el día de hoy al doctor Sabareesh Natarajan, quien es neurocirujano de base de cráneo, cirugía de cerebro vascular, profesor de neurocirugía vascular abierta, endovascular, director del Departamento de Neurocirugía de base de cráneo y microcirugía craneal en el Hospital Universitario Memorial de la Escuela de Medicina de la Universidad de Massachusetts. El día de hoy nos privilegiará con la ponencia llamada La toma de decisiones en aneurismas cerebrales sin romper, una perspectiva dual de expertos neurovasculares. Doctora Natalia.
Yeah, thank you, Dr. Andre, for the nice presentation. My name is Natalia Fedorchenko, and I represent in the organizing committee of the World Congress of Neuroscience, the World of Neurosurgery at your fingertips. We are welcoming all of you today, so thank you for joining us, and thank you for being with us all this week and continue to do so. I would like to say many thanks to the chairman of the Congress, Ambassador of UNESCO Associated School Network, Mr. Jorge Herrera, for the idea of the Congress and for really great organization. Thank you for the cooperation, the Walter Dandy Neurosurgical Society and Dr. Salim Abdulraouf, also Foundation for Brain Mapping, and Dr. Babak Kateb, the vice chairman of the Congress. Thank you to the WAPS Medical Students Chapter in Mexico and Neurosurgical TV for the broadcasting to helping to be in us live all this time and right now as well. Today, I would like to present to all of you our speaker, Dr. Sabareesh Natarajan. He is a cerebrovascular and skull-based neurosurgeon, neurointerventionist, assistant professor of neurological surgery director, open vascular and endovascular neurosurgery director, skull-based and cranial microsurgery program, UMass Memorial Healthcare University of Massachusetts Medical School. So Dr. Sabareesh, you can now share your screen and start your presentation. We are waiting for it.
Are you able to see my screen?
Yeah.
Okay. Thank you for the invite. It's a pleasure to be with you and talk about this topic of unruptured intracranial aneurysm, which is one of my favorites. I know there is a lot of medical students who are watching this too, so I'm going to tone it down a little bit so that they understand everything that we talk about. So at UMass, we have a complete program. We do cerebrovascular, skull-based surgery, endovascular neurosurgery. We have a huge group of stroke neurologists. We do cerebrovascular research, and we train residents and fellows. I think to do a good vascular surgery, you need all these skill sets put together, and that's what makes a good cerebrovascular and a skull-based program. So why are we scared about brain aneurysms? Because they rupture. And what happens if they rupture? 30 to 40% of them die. 15 to 20% of them die before they come to a hospital. And of the people who survive, 50% of them are functionally independent, and a good number of them have deficits for long term. But the risk of rupture is not so high. You know, it's only 6 to 10 persons if they follow them over 100,000 person years. So it's not like every single aneurysm that shows up at your door is going to rupture. It's very important for someone who deals with aneurysms to identify which of these aneurysms that are going to rupture. The other problem is that we also see a good number of small aneurysms rupture, and we have data, at least small amount of data, to show that aneurysms do not shrink when they rupture. So when in unruptured aneurysms, so the 2 to 3% of unruptured aneurysm people in the general population of unruptured aneurysms. So we don't know. So 2 to 3 in 100 people have aneurysms, but we don't know that they have aneurysms. And I don't call something less than 3 millimeters an aneurysm. I call it an infundibulum because I think it is too small. The rupture is extremely low. I think a lot of people who get scared that this is an aneurysm and they come to my office all the time asking for help. I tell them that this is not an issue. You should not worry about this. The other thing is that how do we image these patients? We image these patients by non-invasive imaging. We do not use angiogram in most of these patients. They get MRIs or CTAs. And the quality of this imaging is so high today that I almost don't use a diagnostic cerebral angiogram unless I decide to treat an aneurysm and I want to plan my treatment. That is the only reason I do a diagnostic angiogram. Otherwise, when I do a catheter-based treatment is the only time I go for treatment of an aneurysm. So when I think about aneurysm progression of rupture, I think about there are multiple types. Here you have an aneurysm which we never knew that happened, and then you find it after it ruptured. And then you have an aneurysm that was identified and it grew immediately and ruptured. And then you have aneurysms that you follow over lifetime and then they grow and rupture, and aneurysms you follow that never rupture. So there are 4 categories, and the question is, how are we going to navigate these 4 different categories to identify who we need to treat and who we need not treat? The other category is patients with high risk for developing intracranial aneurysms. One is if you have first-degree relatives, which is your close relatives having unruptured aneurysms or a subarachnoid hemorrhage, and patients with adult polycystic kidney disease and co-occasion of aorta. In these patients, I do family screening only with MRAs and CTAs. They do not need a diagnostic cerebral angiogram for screening. So once we know that the patient has an aneurysm, how are we going to estimate the risk of rupture? That's the next question. The science is not perfect, but we have some guidelines. You can see this is the first study that was published, a huge study, multi-centric, international, published in 2003. And they classified aneurysms as cavernous aneurysms, anterior circulation aneurysms, and posterior circulation aneurysms. And they graded them as less than 7 millimeters, 7 to 12 millimeters in size, 13 to 24 millimeters in size, and greater than 25 millimeters in size. And if you see, I've given a little green, yellow, and a red, just like you see in a stoplight, where it increases a risk of rupture per year. And the aneurysms in the red category I would treat, which is really big aneurysms. The smaller aneurysms you can watch because their rupture risk is very low. So it's important, this is per year. So if you have a patient who is, say, 40 years of age and comes in with a rupture risk of 0.5% per year, in a lifetime, that patient occurs 30% risk of rupture. So it's important to understand that in a younger patient, a smaller percentage will magnify as a bigger percentage. The biggest problem with this study where the PCOM aneurysms were mixed with the posterior circulation, and this is such a general categorization of varied pathology, and we needed something better than just the ISUIS study. So this is a study done by one of my, I know Dr. Morita in Japan very well. He did this study, which is a Japanese unruptured study. Even in this study, the same thing. The size at 7 millimeters was a cutoff at which the rupture risk increases. So 7 millimeters is kind of the golden number. But he kind of separated these aneurysms into multiple other different categories. The most important are anterior cerebrals, where even at 3 to 4 millimeters in size, there is almost a 1% risk of rupture. The other category was the PCOM, where even at 5 millimeters, there is almost a 1% risk of rupture. And once you separated the PCOM off the rest of the posterior circulation aneurysms, the Posterior circulation aneurysms were okay even till like 7 millimeters in size. And the vertebrobasilar and proximal basilar aneurysms, even till around 10 millimeters, they were okay. So this is important to understand. And you can see I can given a color coding here at the bottom. Less than 40 years of age, then, you know, with the yellow or orange, I would treat. If they are older, I have a lesser, more threshold to watch. And if it's red, I would treat them irrespective of how old they are, unless they are really not good ideal candidates for any surgical procedure. This is another score that we base these patients on. It's called as a FACES score based on the acronym population, hypertension, age, size, earlier subarachnoid hemorrhage, and site of aneurysm. This is interesting because it's important to understand the relative weighting of 3, 6, and 10 is very high for size, but for the rest of us, it is not. The other thing is the Japanese and Finnish population, if you see, they have a high score, and this is related to smoking. So I kind of give smoking a weightage of around 3 points. Irregularity of this aneurysm was not put in the scale, but comparing the other studies, I give it around 2 points. That's how I grade it. And you can see that similarly, I see less than 5 green, which I don't treat. 6 to 8 orange, which is if the patient is very young, I treat. 9 to 11 yellow, which is even if the patient is old, I will treat. And 12 and above, I treat everyone. So that's how I kind of in my practice look at these aneurysms and decide who I need to treat and what I need to treat. I've been involved in some of this research at Buffalo during my training. So this is a very important concept, which is it's not just the absolute size of the aneurysm, but it is the ratio of the size of the size of the parent vessel to the size of the aneurysm. So if we have a small vessel, say it's 1 millimeters in size, and an aneurysm on that vessel, which is around 3 millimeters in size, that is a problem, even though it is only 3 millimeters in size, because the ratio of the parent vessel to the aneurysm is high. And this panned out significantly, and we saw that as the size ratio increases, it alters the hemodynamics and separates ruptured and unruptured aneurysms very, very well. And it makes a lot of sense why ACOMs and PCOMs in the Japanese study panned out, because they are smaller vessels. So smaller aneurysms ruptured more in ACOM and PCOMs because their size ratio was bigger. This is one of my passions, which is to study flow dynamics in aneurysms. What we do is we stimulate flow conditions in aneurysms, just like we stimulate airflow conditions around airplanes. And we found out that aneurysms that have a kind of stasis, the blue is stasis, and these are all ruptured aneurysms, and these are unruptured aneurysms. You can clearly see just with the color coding that they are different. And we can separate and know these are ruptured aneurysms and these are unruptured aneurysms. This is one of our highly cited works, and there's been a lot of people who are trying to take this to a further level to put it in daily routine work. So when you talk about a hybrid neurovascular specialist, I don't call myself a neurosurgeon. I don't call myself a neurointerventionist or a neurologist. I'm a neurovascular specialist because I use all these different kinds of tools to treat my patients with vascular disease. When you take simple open vascular techniques, we talk about small craniotomies like pterional craniotomy or a retrosigmoid craniotomy to clip an aneurysm. And then if you want to do advanced procedures, then you can incorporate your skull-based skill set, which includes orbitotomy, clinodectomy, and more skull-based approaches. Sometimes you may have to revascularize vessels when you treat aneurysms, and that involves bypass techniques. And then everyone talks about catheter versus clip. No, that's not that. Catheter versus clip is a very old concept. Now there are so many variations in catheter treatment, so many variations in clip treatment. If you say in endovascular treatment, we have flow diversion with or without coils, which I think is the supreme treatment. Next comes neck bridging devices, which include balloons, temporary stents, microstents, bifurcation devices. Then we have this new technology of endosaccular flow diversion, and simple coiling, which is the gold standard on which all these technologies were compared against. And it's very important to understand when you look at studies, what kind of technology or what kind of treatments were used in those. So when I go to treat an aneurysm, I ask these questions. I think the most important question I would like to highlight is, just because you can treat an aneurysm, you should not treat it. We talked about what is the rupture risk of aneurysm, what is the age of the aneurysm, decision making. That stands good. It doesn't mean that if you can treat it, you should treat it. You can observe and watch a lot of aneurysms. In fact, in my practice, I do not treat around 70–80% of aneurysms I see in my clinic. I watch them. I treat only 15 to 20% of aneurysms that I see in my clinic. The next question is, it's good for us and it's good for the patient. Can I treat an aneurysm minimally invasively, safely, with the same amount of efficacy as open surgery? If that is possible, you should do it minimally invasively. The next question is, what is the permanence of occlusion of a treatment? If you take a clip, is the most permanent way to treat an aneurysm, because the recurrence rates after treatment of a clip is extremely, extremely low. But we have a fierce competitor in the last 10 years, which is flow diversion, where if you can get an aneurysm to occlude by flow diversion, we haven't seen an aneurysm come back. But we cannot do flow diversion in every single case. So it's important to select your patients for flow diversion. And if that's possible, and you think the patient is a good candidate, it is almost an equal treatment as a clip. The next thing to think about is the complication rate. We talked about all those techniques, skull-based techniques, cerebral revascularization, complicated endovascular techniques. It's important to think about simple techniques have low complication. Complicated techniques have higher rates of complications. So if you can address an aneurysm by a simple, low complication methodology and achieve cure for a long term, that's the thing to choose. And then, we all want to go back to work. We want to go back to our lives after treatment. So the hospitals say return to work is important. And then I all the time see this, patients in my office, hey, do you need to open my head to treat this? Opening the head sometimes is necessary. And that's what we've been doing to treat aneurysms for a long time. And if that is the safest way to achieve a good treatment of an aneurysm, that's the way to do it. And then we have patients who have horrendous anatomy in their vasculature who said, can you do this minimally invasive? In those patients, it is your job to convince them that, hey, minimally invasive, even though it sounds so, it is not minimally invasive given all the horrendous vasculature and vascular disease you have. And those patients are better suited for an aneurysm clip. It's important if you do an endovascular treatment that you have an ability to follow up these patients and do repeat procedures, because it's important to wait till the aneurysm occludes and have good follow-up. If I have a patient with a compressive symptom, like patients who have cranial nerve palsies, losing vision, I use open methods. Most of the times, a good treatment with endovascular requires dual antiplatelet therapy. So we need to make sure these patients are candidates for that. And then around the country, around the world, in maybe countries where there is no resources, affordability is an important thing. Endovascular is more expensive than open methods. And at the end of the day, it's about what is safe in your hands, what the patient wants, and can you do that safely? And in my hands, endovascular gets one chance. So I've treated an aneurysm with endovascular once. If it recurs, if there's a problem, I won't push that. I would go right to surgery and I can fix it. And the other important thing in our field is, every day there is new devices that is being manufactured. It's important to look at what their efficacy is, what they do, and resist your impulse to keep using new devices and toys. Okay. So when I think about the supreme top choices, a simple clip reconstruction is a very good method where you don't have a non-complicated aneurysm without any kind of atherosclerosis, no branch incorporation, or if there's compressive symptoms, clip is the way to go. The next equally supreme treatment is flow diversion, which I will show you what that means. But it is indicated in certain aneurysms where it's from the petrous to the pre-bifurcation segment of the ICA, proximal vertebrobasilar or proximal basilar aneurysms. There should not be big branches coming from the neck of the aneurysm, if possible, not bifurcating aneurysms, and there should not be a lot of thrombus burden in the aneurysm. These are the aneurysms that I would select for flow diversion. And if I see that, I would preferentially treat these patients with flow diversion, even to a clip. So this is a small illustration of a flow diversion. There is an aneurysm here you'll see in the video. This is the flow diverting stent that is placed. I'm just going to show this. We are coming from the wrist through a 2 mm hole right brachiocephalic artery, right common carotid artery, and you can see I'm going to climb this catheter in the neck. And you can see that is the aneurysm right there. We are climbing all the way into the head through a 2 mm hole in the wrist to treat this aneurysm. And you will see as time flies by, I'm taking the bigger catheter all the way into the head. Now we get magnified views, and you can see that is a microwire, microcatheter, and that is the aneurysm. So we already crossed the aneurysm. And then now I'm taking a bigger catheter, which is a 5 French catheter, all the way past that aneurysm into the head. Now I'm measuring the size of the blood vessels, and that you can see that aneurysm right there. And I'm trying to deploy a stent in that curvature. Let's see, that is the stent, which is the flow diverting stent, which is going up. And you will see that being deployed. It is like a slingy. So you know, it's very difficult to deploy a slingy around a curve. You will see a lot of push, pull to make it kind of expand to the vessel wall so that it doesn't twist, and it has to lay untwisted opposed to the vessel wall. And it's a technique you learn by experience. It's not like deploying any other stent. You will see here, this is the stent right there. It's like a little, it's constrained still. Now it's opening. You can see it's funneled a little bit. You will see that it's right here. It's funneled. You can see that very well there. And it is constrained till that is the tip of the catheter. So you can see the edges of the stent there. There it is opening. You can see that there in the thing. And it's very important to make sure it doesn't twist when you open it. And it's almost out of the catheter, and you can see that is the edge of the stent there. So now I'm going to take the catheter and kind of knock it to kind of make it opposed to the wall, and that creates flow diversion, which is what it does is it kind of endothelializes the aneurysm neck so that over 6 to 9 months this aneurysm heals. And if this aneurysm heals, it doesn't come back. So this is a very nice. Patients stay overnight. They go home the next day. So it is a very good method to treat. This is the old method to treat, which is coiling, where we have a wire and a microcatheter. You can see that is an aneurysm. And I'm taking the catheter in there, and I'm just showing this because there are a lot of medical students who don't know how this is done. And that is a coil, and you can see that a coil is going in the aneurysm, and that's how you take care of an aneurysm in the traditional way. The problem with this is simple coiling has a recurrence rate. If you follow people who have coiled, if you follow them over 10, 15 years, around 20% of them recur. So you need to follow these people. It's not the end of the road. You need to make sure these people don't recur. That's why I prefer coil as kind of my last option, even though it's the old gold standard method and simple. It is kind of my last option to treat an aneurysm today. So this is, so we're going to go to some cases. This is a 59-year-old gentleman who has a 14 millimeter aneurysm, which we told the risk is high. My endovascular colleagues, I have 3 other neurointerventionists who work with me. They tried treating this with catheters, but it's difficult. You can see here the aneurysm inflow is here. The outflow of the aneurysm is this way and this way, which is like a hairpin bend this way and a hairpin bend this way. And there are 2 branches here. This is an aneurysm very difficult to treat with endovascular. I personally wouldn't have even tried it endovascular. So they referred this patient to me for a clip. So the 2 branches that we talked about on the other side, this is the inflow primary vessel. That is the aneurysm. The other branch is hidden underneath the aneurysm when you see the video. So this is the frontal lobe. Are you able to see the video?
Yes, video is good.
Okay.
You can see.
For some reason, it's not playing continuously. Let me see. Okay, there it is. So that's the frontal lobe, temporal lobe, and that is the Sylvian fissure. We are in very high magnification, and you can see I'm separating the frontal lobe and the temporal lobe. And I am, is very gingerly, it's very high magnification. The vessels that you're seeing are 2 millimeters in size. And you can see I'm almost completely split the frontal and temporal lobe. That is the MCA M1, which is our proximal vessel. I'm assessing to make sure I have a clip size for proximal control in case the aneurysm ruptures. And this is the aneurysm. These are the two branches that we talked about. It is hidden underneath the temporal lobe. I'm trying to dissect the branches and the aneurysm away. That is the inflow. And you can see that is the other branch that is hidden underneath the temporal lobe. I'm trying to dissect and look underneath. That is the other branch that we want to preserve, which is tucked underneath the aneurysm and underneath the temporal lobe in 3D. And now you have an idea of the entire 3D of this aneurysm and you know, where we need to put the clip. So I put a first clip. You can see that all right on the neck of the aneurysm. I see the other branch going the other way, this branch coming this way, and I see the inflow. But there is some calcium and atherosclerosis in the neck, and I'm not sure. So I'm checking and making sure my blood flow in the vessels are fine. The blood flow, when I use a microdoppler and the aneurysm is gone, but then in the blood flow in the vessels are not great. So what I do is I will do a tandem clip technique, which is I put a second clip right next to it and take the first clip so that I give a little bit more flow to the blood vessels. And that's what we did. And now the blood vessels have very good flow. But because there's calcium, I want to put a second clip here to make sure that there is no inflow into the aneurysm. And you see that because I moved the clip, there's a little bit of neck there that is still left. So I put a third clip to catch that. And that kind of takes care of the entire aneurysm. There's a lot of gimmicks and tricks when we start clipping the aneurysm itself. And it's a lot of intuition when we do it. And now I'm checking the blood flow in all the vessels. And you will see that I will do what you call an indocyanine green angiography, which is I inject some dye. And I can see the flow of all the vessels. You see the aneurysm is not filling, but all the blood vessels are filling. That tells that we have done the job. All right. So again, length of stay. This patient was discharged 2 days after surgery on the third day. And you can see the clip there, the aneurysm is gone, and that's important. Length of stay is good. Now this patient doesn't need to come for follow-up, and he's done and gone. This is another lady, 65-year-old lady with a large basilar aneurysm here. It measures around 12 millimeters in size. You can see there is a significant turn of the vertebral artery coming up, which may be a problem if you're trying to treat this endovascular. So what are the, should we treat this? Yes, because it's a large aneurysm, the posterior circulation needs to be treated because the rupture risk is high. Then how do we treat it? The treatment options are open. This is endovascular. What is it? Open, it's permanent, but the risk of complications and problems is around 7 to 10%. Endovascular, the treatment is stent coiling. There's a recurrence risk of around 10 to 15%. The patient stays in the hospital for a shorter stay and the patient can go home. So we give these options to the patient and the patient chooses what they want. Sometimes it's about what the patient wants too. It's just not about what you want to do for the patient. So this patient chose to have this treated by a stent coil. You can see here, this is the aneurysm. You can see that is the basilar aneurysm right there. And you can see here, it's coiled very well, but you can see the blood vessels are coming from the neck. To protect the neck, we have to put two stents. We put one stent from here into this vessel and a second stent from here into this vessel. You'll see it in 3D in this video. You can see that there are two stents and that kind of keeps the coil in the aneurysm. And now this aneurysm is secure. She's almost now 2 years out and she's doing wonderful. She hasn't had a recurrence. So this is another way to treat this aneurysms. And the patient went home the next day without any problems. This is another lady. She's 62-year-old. She has this nasty looking aneurysm in the pecan. You can see there's 3 daughter sacs. There's 1 sac here, 1 sac here, and a 3rd sac here. These vessels are anterior choroidal arteries, which are very important if patient will get devastating strokes if you don't save them. And this patient has an occupation that doesn't allow her to come for regular follow-ups, doesn't want, she wants the treatment and done. She cannot afford to come back again and again to do multiple angiograms, check them and all that. So she wanted this treated by a clip. And yes, we can do this by a clip or I would do a flow diversion. But she didn't want a flow diversion. She wanted a clip. And again, as I said, it's not about what you can do or you should do. It's about what the patient wants. Sometimes what the patient wants is not the right thing, then you can talk them through it. But if they want something that is reasonable, it's okay to do that for them. So here you have this is a picture. You're going to see this video. This is the ICA. This is the aneurysm. There's one dome here and a third. So these are the three lobules. This is the tentorium. This is the optic nerve. And you're going to see this video in a minute. So there we are working. That is the optic nerve. This is the tentorium. I'm sizing a temporary clip just in case the aneurysm ruptures. I can arrest the flow, and you can see now I'm dissecting the aneurysm. Those are the two vessels that I talked about, which is the anterior choroidal vessels, which we need to preserve so that the patient doesn't have a devastating stroke. I'm slowly dissecting all the arachnoid, which is the coverings around this aneurysm, and dissecting them, exposing and understanding the relationship of the aneurysm to those vessels. That is the PCOM artery, which is kind of compressed by the aneurysm underneath the dome of the aneurysm. And you can see as we dissect, this will go and join the posterior cerebral artery in the posterior circulation. And you can see that is the third dome that is hiding. And I'm trying to dissect those vessels, which are the most important vessels to preserve often. This is the third nerve, which is important for eye movement. So a lot of critical structures right here. And you can see that is the PCOM that is going to the PCA. And I'm trying to dissect all these three lobes of the aneurysm from all these critical structures. And now that I'm confident that I've separated and I'm looking around or even on the other side of the ICA to make sure I have everything in place, you will see that I'm trying to put a clip right on the neck of the aneurysm, and I'm watching for that vessel that is very important to preserve to make sure I'm not doing anything bad to it. The other thing I'm watching is to make sure I don't narrow the internal carotid artery, which is the main supply to that side of the brain, and we need to make sure that does not get affected. So there is the clip that goes on, and then I am checking there's no flow in the aneurysm. All the flow in every other vessel looks to be okay. You can see that is the basilar artery at behind the ICA and the PCA and the PCOM. You can see I'm putting a second clip because you can see there is a second dome that is underneath that clip that's still not secure that I found. So I'm going to catch that, making sure I don't take that other vessel that I'm always worried about, which is the anterior choroidal artery. And there goes the second clip on the last dome, which is down there. I think at this point, I am very happy with where we are. And I'm looking at the other side to make sure both the clips are catching. This is papaver soaked gel foam. It's a vasodilator, so that you can see there are two anterior choroidal arteries that were preserved, and that is the ICG, making sure the flow through all the normal blood vessels is okay. So that is the postoperative angiogram. You saw there were big aneurysm right here. It's gone. There are two clips, and those are the two little tiny vessels. They are sub-millimeters in size. They're anterior choroidals that we wanted to preserve in this operation. This we do sometimes, which is when we have a big aneurysm that we need to flow divert, we put in coils and flow diversion. This is a young lady who came in with headaches and visual disturbance. We took her right away for treatment. You can see that big aneurysm in the petrocavernous region. So what we did, you will see in a minute. We take it to the angiogram. This is an expert CT. We can get very good three-dimensional pictures when we do angiography to assess the aneurysm and see. Now we have put in the stasis in the aneurysm already. I put in coils and a flow diverter stent. You will see a 3D CT we can achieve. You can see the resolution of the CT. That is the coils there. And you will see that is the stent. You can see the resolution of the CT. You can get in the angio suite. That's the stent we put in the vessel. Same thing, another view, coils with flow diversion. This patient was again discharged next day. Once this aneurysm goes away in 6 months, it's not going to come back. So it's a great way to treat these aneurysms. This may be the last case, I think so. This is a patient who is 77, so a little on the older side, has this aneurysm, but you see it's not this is the aneurysm. This entire thing is an aneurysm, but there's a lot of thrombus in it, which is clot. And she's coming because she's having progressive loss of her vision. And she's getting blind because this aneurysm is pushing on the nerves for her vision, and she is getting blind. So what are the options? Well, we can put in some coils in this. Is that going to take care of the compression on the optic nerves and give her back her vision? No. Can we do stents, flow diverters? Why would you want to do that with all this clot in the aneurysm? You don't want to do any of those. The best way to treat this is to put a clip in the neck and decompress the aneurysm so that you relieve the pressure of the optic nerve so that the patient can get back her vision. So you can see that that whole thing is the aneurysm, huge. And it's 2.4 centimeters in size. But you can see it's a heavily calcified wall. It's probably stuck to a lot of critical structures, which is what we found. This is the video. So you can see, again, this is the optic nerve, carotid artery, anterior cerebral, MCA bifurcation. And that is the big, giant aneurysm with clot that is pushing on the patient's optic nerve. There I'm putting a temporary clip on A1 just in case the aneurysm ruptures. That is the neck of the aneurysm right there, because the two anterior cerebral tubes are going out, up from here into the interhemispheric fissure. And now that I have dissected the aneurysm neck very well, I'm going to put a clip on the aneurysm neck, preserving both the anterior cerebrals going up. So that takes care of inflow into the aneurysm, but we still need to decompress the optic nerves, which is we need to decrease the mass effect. So what I do is now I'm opening the aneurysm. You can see that I'm cutting open the wall of the aneurysm, and you can see there is so much of clot inside the aneurysm, and I'm removing all that clot to make that big, giant, hard thrombus relax so that it takes the pressure off your optic nerves. You see all the clot is coming out, and you can see how that aneurysm becomes lax. And that is the way you take down the pressure on your optic nerve. Because I could just get one clip on the neck of this aneurysm, I was a little worried what would happen if that clip slips and I would leave this aneurysm open, because the patient can literally die if she bleeds out from this. And I couldn't dissect the wall of the aneurysm away from the back because it was stuck very much to the brainstem and the basilar artery at the back. So you can see already it's so lax. So I decided to suture the wall of the aneurysm. These are 9O sutures, which are very fine, probably much thinner than your hair. And we sutured this aneurysm together. So you know, this is the important thing I talked about. To get to this aneurysm, you need a skull-based approach. You need to have good vascular techniques. You need to have good revascularization techniques. And you need to know, and what are the endovascular options? Are they good? Are they bad? And kind of pick and choose what you do for patients. So someone who just does skull-based, someone who just does vascular, someone who just does endovascular cannot give the best care for these patients. That's why you need a combination of all of these expertise to kind of treat this. And you can see the aneurysm is gone. And this patient, you can see this was the sac of the aneurysm that is pushing on the optic nerve. Now you can see there's space around the aneurysm that we created. And this patient's vision came back completely normal. I just saw her in the clinic a year out of surgery. She's a happy camper. So important that when you have compressive symptoms, address the compression by direct surgery. So I'm going to stop there, and I'm going to open this for questions. Unless you want me to show more cases, I can do that.
Minute. Okay, thank you, Dr. Sabareesh, for the great talk. There are actually a question for you. How we should act if a coil perforates the aneurysm?
So if a coil perforates an aneurysm, first thing to do is not panic. Okay, it happens in ruptured aneurysms, and the first time it happens, you'll hear your heart coming out, but you know you'll get used to it, right? The most important thing is not panic. You're the leader of the team. If you panic, everyone around you panics, right? So the next thing you do is, if the patient has been given heparin, I reverse the heparin, and then what I do is I keep coiling the aneurysm. Most of the times that is the solution, because as you keep coiling the aneurysm, you shut down flow coming into the aneurysm, and that takes care of it. Sometimes the hole is big and that doesn't take care of it. Then we can bring in a balloon through your parent vessel, and you can inflate the balloon temporarily for 3-4 minutes. And what happens is, majority of the time, that stops the bleeding. If the patient is having high pressure, the patient is having neurological symptoms, again, this is why it's important to have a neurosurgeon do this. You can immediately put an external ventricular drain in the angio suite to relieve the pressure in the head. And so those are all the things I do if something like this happens. It's not a common thing, I'll tell you that. I've been in those situations. It's handleable. As I said, the most important thing is not to panic and take care of the situation.
Yes, that's true. And another question, is the same management of AVMs?
AVMs are totally different animals. I think that will require another hour talk. Very different. I think AVMs are treated by surgery, endovascular, and radiation. I do all three of them. Again, the same thing. It's important that the AVM is treated by someone who does all three, so that they can choose the right thing for the patient. If you go to someone who just does catheter-based work, he's going to say, I'm going to treat it with catheter. If you do someone with gamma knife, he's going to do it with gamma knife. Surgeon is going to treat it by surgery. But it's important to have all these things, understand, or work in a multidisciplinary team where each one of us understand and give each other room, right? Surgery is kind of the best treatment if an AVM is resectable. So low-grade AVM, superficial, best treatment today is surgery. Gamma knife, I preferentially use it for deeper AVMs that are not resectable or higher grade. And endovascular is really to facilitate your open or gamma knife treatment. Rarely, deep AVMs, I do transvenous endovascular cure because the risks are high. Becomes the last choice.
Yeah, thank you. Thank you, Dr. Sabareesh. That was the last question from our listeners. Thank you for the great presentation. Actually, for this, our Congress, we have like 3 speakers now who was talking about aneurysm, and every time it has a lot to get to know more, and different example, different cases. I guess you can talk about this topic forever. Like also was Michael Lawton, Salim Abdulrauf, and now Dr. Sabareesh Natarajan. So it's like you are great, because this is something like a bomb inside the brain, and you are dealing with it. So you should to be some kind of really self-confident people who with a lot of knowledge is behind you, because to manage all this stuff, it's like you should spend a lot of time and half of your life to deal with this. So really, I'm really appreciate all these doctors who deal with this, and Dr. Sabareesh like as well too. So thank you very much for the presentation and for your talk.
You're welcome. Thank you, Natalia.